Hi, everyone. We're going to get started. I'm Dr. Margaret Crane, and I'm a postdoc in the Bridge program. And it is my absolute pleasure to introduce Dr. Amy Van Pelt today. And I want to welcome you all to today's Advanced CTR Implementation Science Seminar series. This series is co-hosted by the Advanced Clinical and Translation Research in Rhode Island, or CTR, the Bridge program, which is our implementation science group here at Brown, and ARCH, which is Brown Alcohol Research Center on HIV. Please note that the seminar is being recorded. And yeah, we really want to welcome you all. So today's speaker is Dr. Amy Van Pelt. Dr. Van Pelt is presenting on applying implementation science to advance global health. Her talk will emphasize the role of implementation research in advancing global health and practice. Amy is an assistant professor at the Department of Medical Sciences and the Center for Dissemination and Implementation Science. In addition, she serves as the Associate Director on Research within the Havey Institute for Global Health Ryan Family Center for Global Primary Care. She completed her doctorate. I guess just to give a brief overview on her many expertise, she has expertise on translational research, including contextual inquiry, novel epidemiological investigations, and then also rigorous investigations in the effectiveness of interventions in the global context. So she focuses on increasing the uptake of evidence-based interventions for infectious diseases in resource-limited settings, primarily in low and middle income countries. And she also is an absolute expert in implementation science. So it's going to be a real treat for us to learn from her today. In addition to all that, Amy's a dear friend, so I'm thrilled to have her as well. So Amy, I'm going to turn it over to you to get started. Thanks for joining us.
Thanks so much for that introduction, Dr. Crane. I'm really excited to be with you all to talk a little bit about applying implementation science to advance global health. I want to start by getting a better sense of who's in the room. So I believe we have the chat function enabled. I know we can't come off of mute right now, but I would love for folks to share what your experience with doing global implementation science is in the chat. Feel free, if you have a lot of experience, let me know. If you've never done it, but you're interested in learning more, I'd love to hear a little bit about your backgrounds. We have some folks who are interested in learning more. Sounds like more domestic focused work, but interested. Oh, very exciting. Someone who's going to be pursuing an MPH in global health. Okay. Some MPH folks. Okay, great. So feel free to keep adding your experience and expertise in the chat, but it sounds like we have a range of experience here. Anyone who has pursued or has conducted global implementation research, I'd love for folks who are comfortable doing so to feel free to add to my conversation, add your thoughts, add your input into the chat, and we can have more of an interactive discussion here. I wanted to start, though, by talking about my journey to implementation science. It seems like for many of you, you may be implementation scientists who are interested in exploring global health. But for me, my work in global health is actually what led me to implementation science. Like many of you, I studied global health in undergraduate and then an MPH program that I see some of you will be pursuing, where I really had the opportunity to travel to a lot of resource-limited settings early in my career. And that's where I started to notice these delays in care, a lack of uptake of evidence-based practices, and really just limitations in efficacy research in general in these settings. And I could spend a full hour talking about examples from this work, but just to share a few. So when I was living in Zambia, I was working on an HIV vaccine trial among female sex workers. And the amount of time it would take to get the development of this efficacious vaccine we were trying to do in the lab to roll out to people who actually needed it seemed incredibly long. Or when I was living in Nicaragua, there were a lot of barriers or a lot of reasons folks were not using bed nets that we know protect against vector-borne diseases, but I just didn't understand why they weren't doing it and why they weren't using strategies to help overcome those obstacles. And as you all know from this lecture series, what I started to experience and recognize was this research to practice gap, where we all know it takes on average 17 years from the development of a clinical innovation to the integration of our evidence-based practices into routine care. But in resource-limited settings, it seemed like this gap was even longer. Not sure why my slides are advancing without me, so I'll try to maintain and manage that. But one more interactive question that I'd love to learn a little bit more about you all before we dive into the details of how to do global implementation science. And I have this question here because you'll see the blue question mark at the top of my slide. And whenever I have that on a slide, I'd love for that to be a point of engagement with you all. So let's hopefully have one more warm-up question that's a bit easy for folks to answer. So please go ahead and tell me what the gaps in area of your research are in the chat, and I'll try to manage this phantom slide advancing while you do so. Oh, Davey, I'm excited to hear about your work in Zambia as we talk through the examples and considerations for global health. Linda, you mentioned language. I'm excited to talk about that. We definitely have considerations with linguistic barriers here. I'm seeing a common thread of mental health. Financial considerations are also very relevant for resource-limited settings and low and middle income countries. Great. So it sounds like we have a bit of a audience who knows mental health and work in behavioral health. So feel free to share some of those examples as I lean more towards infectious diseases, and we can enrich the conversation here. So before we just dive into how to do global implementation science, in case there are any new folks on the call, I want to make sure we're all on the same page when we're thinking about what implementation science actually is. So for a formal definition, implementation science is the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve the impact on population health. Or what I like to say is that implementation science helps us move the needle to make sure people get the things that work. So I'm going to come back to this definition at the end of our discussion when we're thinking about global implementation science specifically, so keep this in mind. So why do we actually care about global implementation science? Why are we spending an entire session today dedicated to it? This may not be surprising to you all, but the proportion of implementation science that occurs in high-income countries far surpasses the amount of work that's being done in low and middle-income countries. And I just want to note that throughout this presentation, I have added screenshots to what I consider are key papers that I think if you're interested in global implementation work, you should definitely check them out. And another key point here that may not be surprising to you all is that low and middle income countries experience a high burden of disease. Here's just a basic data visualization that I did where I compared high income countries on the top to low income countries on the bottom with regard to daily adjusted life years for various diseases. And what you can see if you look at the bottom figure here is that the burden in low-income countries is substantially higher across all disease areas, or most disease areas, I should say. So low and middle-income countries are settings in which implementation science would really help us reduce this burden of disease, given the goal is to increase the uptake of evidence-based practices. Unfortunately, the implementation science community has recognized this need. There have been a lot of calls for global implementation science to help us close this research to practice gap, and a variety of scholars have outlined their recommendations for key steps in doing so. And I also want to highlight, given I anticipate there are many researchers in the audience, that NIH has also begun to recognize the need for global implementation science, given there have been a lot of RFAs or program announcements that address global implementation research specifically. One source that I do want to point out is this document by the World Health Organization, or WHO, where they outlined 7 approaches to investing in implementation research in low and middle income countries. And I'll come back to these 7 approaches at the end of our talk, but I want to share this because I think it's nice to see a call for global implementation research on such a large stage, because the WHO, for those who are not familiar, really guides national policies for many countries. And one final source I want to highlight in the recognition for the need for global implementation science are special journal issues. So here's a screenshot from the Journal for Global Implementation Research and Applications, where they had a special issue on implementation science in Latin America specifically. I'll figure out this phantom thing eventually, so bear with me. And my team was fortunate to have our paper published, where we outlined 5 key steps that you can see here, where we recommended things to help empower partners in Latin America to facilitate implementation research. And just to briefly go through those, we suggested 1, that researchers should partner with scholars completing effectiveness research in Latin American countries. 2, that researchers must engage partners specific to the region. 3, targeted training in implementation science must be developed for partners in Latin American countries. 4, implementation science resources require translation into local languages and public dissemination. And 5, local partners in Latin American countries should lead adaptation and creation of implementation science resources. So I give a little bit of a primer to some of the questions that I'm going to ask you all in the coming slides. So keep these points and these recommendations in mind. And finally, just to tie this back to global health and public health, given the audience here, let's think about the implications of facilitating implementation science in low and middle income countries. So I anticipate, or I hope that you all are familiar with the implementation research logic model, where we move from first identifying implementation determinants through implementation outcomes. And in the IRLM, or in the implementation research logic model, and really implementation research in general, we are focused primarily on these implementation outcomes. But if you think about it, those outcomes are a mechanism to improving clinical and population health, given the goal is to increase uptake of evidence-based practices. But unfortunately, across all of these outcomes, both implementation as well as clinical and health outcomes, there are great inequities in low and middle income countries, which really limits the advancement of global health. And we can think about that through some common or key metrics. If we consider the Sustainable Development Goals as a frame of reference, and for those who may not be familiar with the SDGs, these are just global goals that are really key metrics for improving the health for all. And the key word here is all, because it requires contribution from all countries in order to achieve those goals. So implementation science is really going to help us get there if we're doing this equitably and achieve global health impact across all countries. So how do we actually do global implementation science? Hopefully I've convinced you that some people think global implementation science is important, and hopefully at the end of this talk, you all will be interested in pursuing it as well. But throughout the rest of the presentation, I really want to walk through some key considerations for applying implementation science in a global context. So as you know, implementation science requires a key set of assumptions and foci, and I'll use this to guide our considerations and guide our discussion. The first being that implementation science requires that there's an evidence-based thing, and this thing could be an intervention, a program, a policy, etc. And if you think about an implementation science subway map that some of our colleagues developed, we need to first demonstrate efficacy and effectiveness of our thing before we're able to proceed with implementation research. We know this is common principle, common consideration before determining whether or not we're ready for implementation research. But there are some considerations that we need to think about when doing global implementation science. So here's our question mark. Hopefully the phantom slides will not advance and give you my answers in advance. But would love to hear from you all. What are some things that we should be considering for global implementation science when we're thinking about the requirement of an evidence-based practice? Please feel free to add your comments and your ideas in the chat. Government policies. Okay, I'm curious to hear what you mean for that. Appropriateness to the country-specific and regional setting. Adaptable core components. I think that's probably similar to Andrew's comment. I agree whether or not the interventions are actually appropriate. Yeah, those are some great points. If you have more ideas, feel free to add them in the chat. One that I wanted to highlight, exactly, great transition, Ariana, is that there's an ongoing discussion surrounding the conceptualization of evidence-based practice, specifically in low and middle income countries. So if we think about where was our evidence produced, who was involved, is it still valid, is it still effective for the context in which we would be implementing it? And we know that most, or not all, but most of our interventions were often developed in high-income countries, but that may not be effective if we're trying to implement it in Botswana, for example. So I'm really curious to see where our thought leaders in this space continue to challenge this idea, but wanted to flag that there is ongoing discussion related to whether or not evidence is evidence in low and middle income countries when the intervention is developed outside of that setting. And one way that folks have tried to address that issue is through adaptation. I see some folks, Emily put in the chat that adaptation is something to consider. I agree with you, and that can be an entire lecture on its own. So I'm not going to spend a lot of time talking about it today, but I did just want to provide an example from a paper that was on the previous slide where they were adapting a parenting program for underserved populations in low and middle income countries. And in order to do that, they outlined 3 steps for improving the appropriateness of an intervention, specifically for use in their setting, which involved first, learning from the high-income countries and adapting to low and middle-income countries. Second, strong partnership and engagement of the local community. And then third, optimizing the intervention. And I wanted to share a specific tool for folks who are interested in adaptation, which is called Adapt It. I'm currently working on a project in Ethiopia where we're using Adapt It to adapt and implement suicide prevention among youth. And we're following this iterative process where we're integrating constituent feedback throughout various steps. So if you all have any questions about Adapt It, I'm happy to answer them in the Q&A portion. The second assumption for implementation science is that partnership is key. We know this work cannot be done without partners, but that's especially true if we're doing global implementation research. So what are some of the considerations that you all think we should be making or having when we're doing global implementation research considering partnership? The needs of the partners, completely agree, Hannah. The right people in the room. Be curious to know or hear your thoughts on who are the right people when we're doing global implementation work. Partners to inform the policies, agree. A mix of constituents, right? So what perspectives are we bringing in? Community partners, academic partners, co-design. These are all great thoughts. And I think probably cross-cutting themes for not only global implementation research, but in general implementation work when we're working in community-based settings. So one that I wanted to highlight first related to that point is that our local partners have a better understanding of our local context in which we'd be implementing our thing. So really partnership is critical across the full research process, and our partners should be at the table at all steps, from first the co-creation of research and identifying our priority areas, which I heard called out in the chat, to data collection and analysis, and then also thinking about dissemination, which I'll talk about in greater detail at the end of our discussion. But I wanted to flag one paper that introduced a lot of really interesting theoretical ideas related to partnership when we're thinking about scholars from high-income countries and partners from low and middle-income countries, specifically related to things like power dynamics. So if you all are working in this space and want to navigate this space, I encourage you to check out this paper and think about how can we actually be navigating power dynamics, which we know exist when we're working between high-income countries and low and middle-income countries. Another key consideration related to partnership is to consider who has a seat at the table. So I heard that called out in the chat as well. So who are your key constituents? Of course, like all things in implementation science, context is going to determine who those key constituents are, but there are a couple of cross-cutting themes in global health. For example, the Ministry of Health often influences and directly informs health programs. So they're often a group that you want to be working with and partner with from the beginning for your work. Another common group are community health workers or health promoters. And I'm sure if folks add their thoughts or their experience, you can list other constituent groups that are key in the settings in which you're working as well. And to just concretize partnership, I'm going to share a brief example from one of my research projects throughout some of these considerations. First, starting with this work where we were trying to prepare for the implementation of a computerized neurocognitive battery for children affected by HIV in Botswana. So if you look on the right, you can see that we had partners from various institutions, both in the US and in Botswana, including academic and community partners. So I heard Margaret or Dr. Crane call that out in the chat. And another key partner I wanted to highlight was a pediatric HIV clinic in Botswana, which is represented by the logo with the map of Botswana. And they were really our key partners for the success of all of this work. And if you look at the schematic on the left here, some of the ways in which we worked together included first sitting down and having meetings to talk about the key issues and really identifying this pre-implementation contextual inquiry that was related to this battery as the focus for our project. Folks, they provided input on the study design and mentorship, both informally and formally on NIH grants, which I think is something important that we want to be considering when doing global health, is that sometimes our partners are not included in the grants. Partners were involved in the recruitment and the data collection process, given they had greater familiarity with the potential participants. And finally, they provided invaluable insight into the interpretation of results, which helped us with dissemination across a variety of platforms. And another key consideration related to partnership in global implementation research specifically is capacity building. So if we think of some of the flagship implementation science trainings that you see here, they're often facilitated in high-income countries for researchers from high-income settings. And these are great. I am a faculty member at the Penn Implementation Science Institute, so I think these are fantastic programs. But I do think we need to increase capacity building for partners in low and middle income countries, specifically for folks to lead the research themselves and not just partner from scholars from high income countries. So when we're thinking about facilitating capacity building, we need to be thoughtful about the competencies that may be needed specifically for global implementation science, which I think these authors here outline really well. So if you're conducting one of these programs, I think it would be helpful or beneficial to outline your curriculum aligned with some of these competencies here. And fortunately, there have been some efforts to build capacity for our global partners. So I want to highlight a couple and some, I think, the strengths and the limitations with each and where we potentially could be moving in the field. So just to start, one of the massive online open courses was facilitated by the groups that you can see listed here, where they translated their training into Spanish, which I think is great. It's helpful in removing some of those linguistic barriers to training. But that's just the first step, and I think greater efforts really need to be made. So then moving into the high IRI, which is a counterpart to the Implementation Research Institute that was listed on the previous slide, they focus specifically on global health and include participants from low and middle income countries, which again, I think is a great next step in increasing access to this training and to this capacity building. But this final image is where I think we really should be going in the field. Yale partnered with Mexico to develop an online implementation science course that not only first removed those linguistic barriers, but also incorporated examples that were relevant to their setting. And I think this is the model that we should be moving forward with. The slide advanced for us, so I'll take us into the last point on partnership. Again, we could have a full lecture on partnership for global implementation science on its own, but I did want to just highlight that there's a specific mechanism for capacity building for our colleagues from low and middle income countries specifically that perhaps may be of interest depending on who's in the audience here. The D43 is a more intensive training program for predoctoral and doctoral students. And this program can be developed in a variety of topical areas, which is nice. So it's not limited to one disease area. And we currently have a D43 that's in implementation science in Botswana that's currently under review. So stay tuned for that, but definitely check out this mechanism if you're interested in facilitating training programs with partners in low and middle income countries. So transitioning into the next key point here, we know that context in implementation science is not seen as a problem. And I contrast that to traditional effectiveness or efficacy studies where we often try to design or control for differences between sites, but we know in implementation science that context is considered and it really influences the design of our implementation strategies. So my question to you is, how may context be relevant, or what considerations related to context should we be thinking about for global implementation science? Health system infrastructure, access to technologies, right? So what type of barriers may exist in those settings? Local needs, multi-level perspectives, agreed. I think that's also very helpful for all implementation work, but agree with you that in this setting, it might have even more influence. Cultural norms, right. Great thoughts. So I agree with you. And I am going to just share a couple of them, but all of the ones that you, or all the ideas that you shared in the chat are definitely relevant for contextual factors in global health settings. I'm sure you all are familiar with the Consolidated Framework for Implementation Research, or CFIR, and I just mapped on a couple of global health factors that are quite common when we're thinking about determinants in these settings. So for example, resource availability may limit our ability to implement our thing, or the intervention may be too expensive and therefore folks can't afford it. There may be specific players, like I mentioned, community health workers, that we need to consider when we're thinking about the implementation process. And there are a lot of other ideas that we could brainstorm here, but a few factors that may not be relevant to some of the domestic work that are quite common in global health that we need to keep in mind. And I want to share this through an applied example related to that neurocognitive battery work in Botswana that I mentioned previously. So here are some of the results of a qualitative study that we did where we elicited perspectives from medical constituents in the public sector in Botswana, and they shared a variety of factors that may affect the implementation of our computerized neurocognitive battery. So for example, they described things like a lack of awareness of cognitive impairment in the community. That may be common for folks who shared that they work in the mental health space, that may not be as understood in some of the countries that we're working in. Stigma and labeling kids with cognitive impairment as stupid, again, relevant to mental health. A lack of understanding often results in labeling and stigma. The need for approval from the Ministry of Health for implementing new interventions. This is quite common across all studies that we work in. Staff shortage in clinics that lead to folks being overworked and having minimal time, and therefore they're reluctant to implement new things. Here we're doing a neurocognitive battery, but also I do a lot of work in mental health in Botswana. And I can tell you that for the longest time, one of my colleagues was the only clinical psychologist in the entire capital. So obviously this leads to a lot of challenges related to staff shortage. A couple of other to highlight here is that the computerized nature of the battery was both a barrier and a facilitator. And we also had a lot of ideas for implementation strategies that involved using the existing workforce, which I think is quite common in our global health work, and targeting a variety of settings. So thinking about schools and clinics to increase reach, because our healthcare systems look different in other countries and folks may not have access. So thinking about how can we reach the people where they are. And if you work with kids, often everyone is in school. So it's a great place to think about implementing interventions. And finally, the last key point that I want to mention related to implementation science is that we really have this robust set of specific frameworks and models and theories, which are great. They help us design and execute our implementation research. But there are a lot of considerations that we need to make when we're thinking about theories, models, and frameworks when we're applying them to a global health context. So I'd love to hear from you all. I think I heard a couple in the beginning when we're thinking about global health, but what are some of these key considerations for theories, models, and frameworks in global implementation science? Health equity, how is that coming into play with our tools and our resources? Trusting researchers. I think some of these might be cross-cutting across all of the considerations, but I see how they're connected to theories, models, and frameworks. Capacity buildings. Who is in the outer context? So NGOs may be a bigger player in some of our low and middle income countries. I agree with that. I want to highlight, I think it may have been Linda, but please correct me if I'm wrong, that mentioned linguistic factors earlier on in our conversation. That's definitely something we should consider as well, but agree with all of the factors that you all shared or all the considerations that you shared in the chat. I mentioned though linguistic factors because something that we need to think about is that most of our tools for implementation science were developed in high income countries, which presents then limitations for the application of those in other settings. So for example, we may have language barriers, accessibility issues, conceptual clarity issues, and I'll walk us through two ideas in greater detail. So the first is related to those linguistic barriers, that the fact that most of our tools exist in English presents barriers for actually being used in non-English speaking countries. And one project that I was really excited about that we recently completed was trying to start to tackle this issue, where we translated ERIC, or the Expert Recommendations for Implementing Change taxonomy, into Spanish, following the WHO guidelines for translation, which you can see here, that's just forward translation, back translation, and then piloting however you choose to pilot. And we're currently working on translating CFR 2.0, so stay tuned for that. But I want to share this because one, linguistic barriers are a huge issue in global implementation work when we're trying to use the tools that were developed. So we're hoping that this will increase access specifically for our Spanish-speaking colleagues, and then therefore promote more locally led research. Here's just a screenshot of the translation for folks who are interested. I did want to share this though, to highlight one key issue that came up during our work. And this was related to difficulties in translation. So a lot of our words that we were trying to translate had a linguistic equivalent in Spanish, meaning we could actually translate it into Spanish, but there was no conceptual equivalent. And There are a lot of words that I could think of, but the ones that are coming to mind right now are the financial strategies in ERIC, because ERIC was developed in the US based on a US healthcare system, which is very different than countries in Latin America specifically. So some of the words related to the payment or the reimbursement just did not make sense because there was not an equivalent thing or an equivalent infrastructure in some of our countries. And this came up in other projects as well. So this was not unique to our study. There was this systematic review that you all may have seen that looked at the use of CFR in LMICs, which revealed again that there were a lot of constructs that were just not compatible in these settings. I do want to also highlight, though, that they proposed a new domain as well called characteristics of the system that was related to things like external funding priorities and resources that are really important considerations for this context. So as Margaret mentioned, NGOs may be more important in low and middle income countries that may not have been part of CFR originally, but thinking about who are the players, what are the factors, what are the determinants in this setting, characteristics of the system came out among a lot of these studies as something that needed to be added for using CFR in this context. So I just want to highlight this because I think it's important that we need to be continuing to assess the relevance and the appropriateness of our frameworks when we're using them in global contexts. And hopefully in the future, we can move towards having some of our global partners develop the tools from the start so they can incorporate some of these contextual nuances from the start rather than us trying to adapt and utilize them in settings in which they are not designed for. Okay, so those are our key principles for implementation science, but there are a few other pieces that I wanted to highlight when we're thinking about global health specifically, and Hannah queued this up in the chat very well. First being health equity specifically. So there's been a tremendous movement in the field to incorporate health equity in implementation science, and we've seen that through the creation of frameworks like the Health Equity Implementation Framework and a variety of papers from our thought leaders who are outlining recommendations on how to integrate health equity into implementation science. So I want to go back to our definition of implementation science from the beginning of our discussion, because I think that the definition of global implementation science really should always include this keyword at the end when we're thinking about how to implement things to improve population health equitably. So I say that because in low and middle income countries, or in a lot of resource limited settings in general, there are greater health disparities and inequities in healthcare. And there's specifically an increased burden among historically and systematically marginalized populations in these settings. For example, Indigenous people or transient populations. So if we're thinking about applying a health equity lens to implementation science in this setting, we can help try to close that research to practice gap and reduce the burden of disease among these key groups. So we need to always be thinking about how are we doing global implementation work equitably, and it should not just be this additional thing that we could be considering, but instead we should always be doing global health global health equity related work in implementation science. And the last point I wanted to discuss is related to dissemination. I mentioned that I would come back to this point. So in general, there is a disparity in the number of authors from low and middle income countries on pretty much all global health related publications in all disciplines. But given that implementation science is partnered research, I do want to call this out because we need to pay specific attention to this issue when we're doing global implementation science. I think there are a lot of different thoughts on how you can approach this, but my recommendation is that every paper should include multiple local authors, not only to be reflective of the work that they're truly doing, but really to amplify the voices of our local partners and to provide nuances and keen insights into the discussions and the implications of our work to really make it stronger. And related to our papers and our dissemination, I did want to mention that there are a lot of journals that accept global implementation science, which is exciting. But for folks who are perhaps newer or just getting interested in the field, one journal that may be of particular interest to you all for both exploring global implementation work, but also submitting work in the future is global implementation research applications. And with all of our work, I wanted to also talk about presentations. We should be thinking about dissemination in all of our formats, but specifically for global implementation science. So for things like conferences and presentations, we should be thinking about when it's more appropriate or really more effective to have local partners present this research or present our research. And I say that because at the end of the day, implementation science is all about moving that needle to make sure folks get the things that work. So we need to be thinking about who's the most effective deliverer of that message. So going back to the neurocognitive battery work that I mentioned, we were quite fortunate, I would say, to have our work accepted to be presented at a Ministry of Health symposium in Botswana. And I led all of this research, but my Botswana-based mentor is the one that gave this presentation on behalf of the team, given who the audience was. Just for some background information, he was on the presidential task force in Botswana during COVID. So he clearly had great influence in the Ministry of Health as well as in Botswana in general. So he had a stronger chance in convincing the Ministry of Health folks that we needed to implement this battery. And since we know that the Ministry of Health is really critical for success, it was important that we had him deliver that message. So something to think about. I know we get really excited about the work that we're doing, but we may not be the most appropriate or effective person to present that at the end of the day. So working in teams is pretty critical here. I also want to highlight, related to presentation, that we should be making a concerted effort to share the research back with our partners in our community. And I know this is important for all community-based implementation work that we do, both domestically and internationally, but we hear time and time again in global health that folks never get the loop closed. They never hear what happened. We just come in and we do a project with them and then we leave, and it's not a feeling that they enjoy. So want to shout out here that we should be traveling back, sharing the results, communicating what we found with our constituents and with our partners. So here's just a photo of me from that neurocognitive battery work with one of our team members, Sume, on a recent trip to Botswana, where the whole trip was focused on going around and sharing our work with our partners, both at the clinic, the ministry, a variety of settings. So I think we're doing pretty well on time here. So to wrap us up, I know that was a lot of information. What I'm hoping you can walk away from this lecture is recognizing that, of course, context is key for all implementation science, but specifically global implementation work. There are some limitations in our existing tools for use in low and middle income countries, and there's really a need to increase capacity or global implementation work. But there is a great opportunity, fortunately, for facilitating an increase in global health impact by doing global implementation work. Davey, I see your question. I look forward to talking about that in a couple of minutes. So please hold your thought there. So just to close, I want to bring us back to the WHO recommendations for investing in implementation research. I'll share that I populated my slides before I read this document, and then you all shared a lot of great ideas and great considerations for global implementation work in the chat as well. So I wanted to see at the end, how did we do? How did we align with the recommendations that they outlined for doing global implementation work? So first, they said that we should be including stakeholders from the outset. Second, they said we should be embracing the diversity of being involved in implementation research. Third, they said that we should expect and enable implementation research to evolve. Fourth, international partnerships are important. Join one or form one. 5, integrate training, mentoring, and fellowships into implementation research programs. 6, create and communicate clear funding criteria. And 7, embed implementation research into health systems. Okay, so I think we did pretty well, but I like how they outline these recommendations, and I think as we close this talk today, we can use these as our marching orders for what we should be considering and how we should be pursuing global implementation research moving forward. So I posed some questions in case folks weren't chatty, but I've loved the engagement in the chat. So I will advance perhaps to the closing slide and would love to hear your questions instead, but we can come back to these here if we need to. Those being, what are some additional considerations that I didn't highlight that you all thought of for global implementation science? What parallels do you see in your community-based work for those who said you do domestic work? And really, how can we promote more locally led research? But I'm happy to take your questions first. Feel free to put them in the chat, or if you think of something later, you're welcome to email me.
Wonderful. Thank you, Amy. So at this point, it's our Q&A portion. So as Amy said, feel free to put questions in the chat. One initial question to get us started is, what are some key learnings from implementation in low and middle income countries that you think are really applicable in the US context as well?
Those are good questions. Honestly, the things that I just mentioned for global implementation work, I'm noticing have parallels to the work that I do domestically in community-based settings. So we talk about partnerships. That's critical when we're doing our domestic work as well. Context, of course, we know is a cross-cutting thing. So in my global health work, the Ministry of Health drives decisions and influences whether or not something could be implemented. But if I think about what we're doing domestically, when I say domestically, I work in like community-based clinics. It's often the public health departments. So there's always going to be some sort of driving influence, I think, in what we're doing, and knowing who those key constituents are and making sure you have buy-in from them from the beginning is something that I'm recognizing is in a lot of my domestic work, and it's not exclusive to the global health work. Some of the other key considerations, I mean, the linguistic barriers have come up too. I'm doing a study in Chicago that we ended up having to do in both English and Spanish because we know we're not a country that only speaks English, and we have a lot of different languages that are spoken, and often those populations experience greater disparities in health. So thinking about how can we be translating the work that we're doing here and not just thinking about translation when we're working in other countries. But there are a lot of different factors, and I think you all shouted out and highlighted some of them in the chat as well about like trust. I think that's cross-cutting in global health and community-based work as well.
Awesome. Another question is, what challenges or opportunities have you seen when partnering with ministries of health in other countries? Like, how open have you seen them be to implementation work? And how much have you seen them be open to, external ideas versus proposing their own ideas for priorities for research?
So I think they're very receptive. It's interesting because a lot of times they're like, we've been doing this for so long, we just don't call it implementation research. We just implement things. And I agree, they're great experts in the implementation of public health programs. So they're definitely open to the idea of doing implementation research. Something that I've heard a lot is that they want us to talk to them before the funding even arrives. And I feel like I'm guilty of waiting until I get this new grant, bringing it and being like, okay, great, like we have this project, we'd love support. But they, in my last trip actually to Botswana, they were like, no, we want to hear the status of how the grant is under review, all of that, so we could prime people that this is on the horizon. So they're definitely interested. Challenges, I think one of the biggest challenges is the fact that we operate off of external funding like NIH, and it takes a really long time. And once we get buy-in from the Ministry of Health, they're like really excited and ready to hit the ground running. And we're like, oh, wait, like we may not actually get this money until 7 months from now. And that's when we can start the project. And I hear that a lot with ministry, but also a lot of partners in general that I work with in global health settings where they're like, okay, like, why are we not starting this now? But the mechanisms that we're operating under often like create challenges with our timelines.
We have a question from Dr. Linda Guzman. which is which trainings or resources do you recommend for implementation science trainees interested in learning more about global implementation science? For example, are there any conferences you'd suggest?
Yeah, so depending on how all in you want to go, or how the all in the trainees want to go on global implementation science. So the high IRI is the HIV Infectious Disease and Global Health Implementation Research Institute out of WashU. That is one that is a more intensive 2-year fellowship program. I believe one of your bridge people are doing the normal IRI, so perhaps could give some input on what that looks like, but it's a pretty parallel program. It's just very specific to global health. And they bring in scholars from low and middle income countries, as well as scholars in the US who work in that space. So that would be one that I would recommend if someone wants to actually go and pursue and lead a career in global implementation science. If you want more of a light touch, I think a lot of our just traditional implementation science conferences like Academy Health DNI, they have tracks that are specific to global health. So it may not be the focus of the entire conference, but it's an opportunity to go and perhaps craft your schedule to attend the global health related talks if you want to do a conference format. The other thing that I would mention, I have not been to this conference, so I can't speak to what it's like, but I know the Global Implementation Society, GIS, they host a conference that I believe is biannual. So that could be one that is clearly just focused on global implementation science. Again, I'm not really sure what it looks like, but I know it's out there as a potential option.
Wonderful. Great suggestions. Thank you for those. The next question is wondering a little bit about barriers to sustainability in the work you've done globally, and any strategies you've noticed for how to overcome those barriers to help implementation efforts be more sustainable in low and middle income countries.
Yeah, so financial barriers are the biggest one when we're thinking about, well, there's a couple, financial and then staff. So the financial piece, I think, is obvious that often we're doing our implementation work off of a grant. When the grant's over, how are we going to sustain that program? I don't think that's unique to global implementation science, but I think it's a factor when we're thinking about low and middle income countries, because something related to that CFR systematic review, when they mention characteristics of the system, is that a lot of times the funding dictates the priorities of our key partners. So if they're getting funding in cancer, they're going to go do cancer work. If they're getting funding in mental health, they're going to go do mental health work. So if the funding mechanisms that they have are not necessarily aligned with the type of work that we were doing, it makes it difficult to think about how are we going to partner and sustain that in the future. Ideally, a strategy to overcome that is to get that buy-in from the Ministry of Health from the very beginning. So once we roll out and we're finished with our project, there's already a plan in place that how we're going to integrate this into the ministry, or how we're going to integrate it into something else to sustain that when we're done. The other one is related to staff shortages, not only staff shortage, but also staff turnover. So a lot of settings that I work in, if it's a district health clinic or it's a government run clinic, folks are assigned to the settings or assigned to the clinics that they're supposed to be working in. So you may have a situation, and this happens a lot, where you go through the whole training process, if training is one of your implementation strategies, and you start your implementation trial, and then that person gets plucked and moved to another clinic. And then you're like, oh shoot, now we're starting over again. And I think that actually does create a lot of sustainability issues, because if you come up with all of these implementation strategies and then your whole workforce changes, then what are you doing? Are those strategies still relevant? How do you overcome that? That's a difficult one, because you don't really have control over where folks are working. But if you can think about integrating some of the more higher up people, like the matrons of district health clinics that don't move from place to place, and integrate them into some of the strategies rather than just the frontline deliverers, they could hopefully translate some of the training and translate some of the information. I've at least noticed that's been somewhat helpful.
Wonderful. I'm going to ask a question because I know some of your interests personally. I know you're interested in refugee and migrant populations. I'm curious how you found using implementation strategies in those settings to be.
Yeah, that's a great question. So I would say I feel like they're different depending on what we're thinking about there. So if we're thinking about like refugee and migrant populations that have resettled in the US and they're not still in transit, I think that's quite different. And we could be working with them in the same way we'd be working with other populations. Of course, some of these issues related to cultural factors, even though they're in the US, there still are cultural factors that they're bringing with them from the countries that they were living in, as well as linguistic issues, a lot of things like that. But I differentiate that from if we're trying to work with folks who are still actively in transit. And that would be like working in refugee camps or working with internally displaced populations in other countries. That is so hard because there are a lot of other priorities often to address, thinking about just basic survival and what do they need to do, and what are their basic priorities. And oftentimes in crisis situations, things go very, very fast. And we like to say that implementation science speeds things up, which I think it does, but we also take a long time when we're doing our studies. So it isn't always compatible with the needs when you're thinking about refugee camps or populations that are currently in transit. So I have not cracked the code on that one of working with the populations that are still in transit. Would love to hear from folks who have successfully done that. But I think if we're thinking about who's currently living in the US or living in other resettled areas, some of what we talked about today would still be relevant. Oh, thanks, Jen Paul, for sharing the upcoming GIS conference. It looks like it's in Nigeria.
Wonderful. Any other questions? Well, I want to encourage you all to come to next week's talk. Actually, it's in 2 weeks. I think we're taking next week off, so November 12th. Dr. Kara Lewis is talking about applying implementation science. Actually, that is Amy's talk, is the title there. Not entirely sure Kara's talk. I'm guessing it's probably about mechanisms. But yeah, exploring implementation science methodologies and mechanisms to advance impact, efficiency, and equity. So I just want to take the time to thank Dr. Amy Van Pelt for coming today and talking about global implementation science. I know we've all learned a lot, and so thank you for attending as well.
Thanks for having me, everyone.